So perfect anatomical reduction is required in order to manage the talar neck fractures. So from 6 weeks to 6 months after performing surgery, you go on observing the patient for avascular changes in the body of the talus. Now there are two possible outcomes. One is that in the body of the talus, if there is a presence of sclerosis, all right, if in the body of the talus there is a presence of sclerosis, how will the sclerosis looks like? Imagine this is the distal end of the tibia, this is distal end of the fibula, and this is the body of the talus. And in this dome, this zone is found to be more white, more dense in comparison to the normal. That means it has gone into AVN. All right. On the other hand, if the body of the talus, if this articular or periarticular region of the talus remains radiolucent, if it remains radiolucent, that means the patient has not achieved AVN. That means there is no AVN. For example, if this is the distal end of the tibia, fibula, and this is the talar bone, and this zone is again radiolucent, having the similar density of the bone as is seen in other regions. So that means there is no avascular necrosis in the body of the talus, and whatever you have you wanted to achieve by the management of this talar neck fracture, you have achieved it successfully. All right. So that is what the Hawkins sign is. This is known by the name of Hawkins sign. So it could have two outcomes. If there is a sclerosis, it has gone into AVN. If there is no sclerosis, that means there is no AVN, and it is going to have union with the best possible outcome. All right. So this much you need to remember in the aviator fracture. That means fracture neck of talus. So we have started this topic with the fracture neck of talus. As you can very clearly see in this picture, in this X-ray, there is a lateral view and there is a fracture in the neck of the talus, which is clearly visible. And over a period of time, if it is not fixed with the perfect anatomical reduction, the possibility of non-union and AVN are very, very high. Hopefully everything is clear related to this topic. Yes, if you want to know the name of classification for this particular fracture, means if you just want to know the name of classification, then the name of classification is again Hawkins classification. All right. The Hawkins sign we have talked about is the name of classification also. Although you need not to go into the details of what are the 6 different types of the talar neck fractures according to Hawkins. Next, as far as calcaneal fractures are concerned, there are 2 to 3 lines which you are bound to remember. The first one is mechanism. The mechanism is fall from height. You know, the calcaneal fracture are also known by the name of lover's fracture, but actually in reality or practically this fracture is seen more in laborers, all right, because individual who is involved in the laborious activity, in the construction activity, falling from height, landing on both the feet on the calcaneum, resulting in the damage, or a burst fracture on the calcaneum. So fall from height, every time you see a fracture of the calcaneum, it is because of the fall from height. So that is the mechanism of injury. Point number 2, as far as the name of classification is concerned, it is just Esec-Lopresti classification that you have to remember. You need not to go into the details of what the Esec-Lopresti classification is. But yes, we are expecting this angular identifications around, which are created around the calcaneum, which could be asked in the form of a question, and then they will ask what is the name of the angle or what are the abnormalities which are related to this angle. You know, there are 2 angles which could be created. So angles around the calcaneum, or if there is a fracture of the calcaneum, the treatment would be decided by constructing these 2 angles. All right. Now there are 2 angles around the calcaneum. One is Bowler angle. Now, what is the significance of this Bowler angle? That it is an acute angle, because normally the value of this Bowler angle is around 20 to 40 degrees. All right. The normal value for this Bowler angle is around 20 to 40 degrees. So it remains acute, less than 90. Other one is the crucial angle of Gisane, where the value is around 95 to 105 degrees. All right. So it is obtuse angle. It is, as you can see, it is more than 90. It is obtuse angle. Why am I writing the word acute and obtuse? So as it becomes much easier for you to identify that whether the fracture is Bowler constructed or Gissin constructed. Otherwise, what you have to remember? You have to remember the names of two lines. You have to remember 4 points in order to construct those angles. But simple, if the angle constructed is less than 90 around the calcaneum, around the ankle joint, it is Bowler angle. But if it is more than 90 around the ankle joint, it is Gissin angle, crucial angle of Gissin. Now, what happens in the fractures of the calcaneum? You see, in calcaneal fractures, that means intra-articular fractures of the calcaneum, what will happen? The Bowler angle decreases. It is further decreased. That means acute will remain acute, while the crucial angle of Gissin, this Gissin angle, it increases. All right. So in fractures of the calcaneum, the Gissin angle will be increased further. That means if the angle is constructed in a normal or in a fractured calcaneum, the Bowler will remain acute for your identification. And if the angle is constructed in a normal or a fractured calcaneum in the form of a Gissin, and if it is obtuse, then it will remain Gissin, all right, for your identification. So you need not to worry about the points. You need not to remember about the points, about the signs. You just have to go into the details of remembering it in the form of acute and obtuse. All right. So this is what you need to remember about the calcaneal fracture. Don't go into the details of Esec-Lopresti types, the primary type and the secondary type. Don't go into the details of Sanders classification, which is CT based classification. Don't even waste your time in the management of the calcaneal fractures. Just by the application of this slab and wait and watch is something that you have to go for. Peeling of the skin is very important as far as management is concerned, because calcaneal fractures can also result in a compartment syndrome, all right, because of the tight space. Next comes the Lisfranc fracture dislocation. You know, we were teaching this topic with the hope that one day they are going to ask about this. Why? Because this is the only fracture which has got an absolute indication in the foot to be managed by surgical intervention. Means, how many fractures have you seen in the foot which are managed by surgical intervention? If there is a fracture of metatarsal, if there is a fracture of any phalanx, if there is a fracture of any tarsal bone, all of them are treated by conservative. That means below knee cast or below knee slab. But this is one such fracture which has to be managed by surgical intervention. That is Lisfranc fracture dislocation. This is the question which came into existence in 2022 for the first time. So what is Lisfranc fracture dislocation? It is the fracture base of second metatarsal. Now my question is that why it has to be managed surgically? What is the reason for this surgical management? You know, imagine if these are the metatarsals 1, 2, 3, 4 and 5. All these metatarsals are connected by a intermetatarsal ligament. Alright, this is 1, 2, 3, 4 and 5. All of them are connected by intermetatarsal ligament. This is just a rough diagrammatic representation. But there is no such connection, direct connection in between the first and the second one. They are connected through the tarsal bones. Imagine if there is a fracture in the base of the second metatarsal, then this entire ray of metatarsals will be deviated. This entire ray of metatarsal will be dislocated. Alright. In order to hold this dislocation, it has to be fixed by open reduction. So you open it, you reduce it, you fix it by the placement of either Herbert screw or by the K-wires, as is being done over here in the fracture of the base of the second metatarsal. All right. So always the treatment for these kind of the fracture is open reduction internal fixation always. And this is why it is considered to be a exceptional kind of a fracture where the management is different from all the other bones which could be managed. As far as Jones fracture is concerned, it is the simple avulsion fracture base of fifth metatarsal. Avulsion fracture base of fifth. You know, fifth metatarsal base, when it is avulsed, it is pulled. So avulsion fracture base of fifth metatarsal because of supination injury. Yes, the reason, you know, the mechanism for causing this Jones fracture is because of supination. And you know, majority of these fractures are very, very commonly observed in obese individual because they are not able to get accustomed to those irregular surfaces or acute traumatic event. All right. As a result of which, because of this supination, there will be a forceful avulsion which might break the base of the fifth metatarsal also. So that is what the Jones fracture is. Now let's have a discussion on the soft tissue injuries around the knee joint, and very important, very practical scenario is the injury to the anterior and the posterior cruciate ligaments. Now let's have a discussion first of all about the ACL in related to the points. Now point number 1 are the attachments or is related to the attachment. You know, the way the anterior cruciate ligament it runs in the knee joint is the way you are putting your hand in the pocket. That means downward, forward and medially. So it will help you in identifying the structures the anterior cruciate ligament is attached to. All right. So before we talk anything related to this ACL injury, let's have a discussion on that way what exactly are the attachments of the ACL. Now imagine this to be the distal end of the femur and this is the proximal end of the tibia. And here we are having the fibula. Now, as I told you, this is the lateral aspect, this is the medial aspect because fibula is there on the lateral side and this is how you will identify the lateral and the medial part of the knee joint. Now, ACL is the intra-articular, that means inside the knee, a kind of a ligament which is present from distal femur to proximal tibia. And when you move your hand downward, forward and medially, the way you are putting your hand inside the pocket, that is the direction of the anterior cruciate ligament. So obviously, the anterior cruciate ligament is going to be attached onto the lateral condyle, onto the inner surface, that means medial surface of the lateral condyle, and that too on the posterior half of the medial surface of the lateral condyle. So if we talk about the anterior cruciate ligament attachment, point number 1, the proximal attachment of the anterior cruciate ligament is the posterior half of medial surface in lateral femoral condyle. Lateral femoral condyle. So this is going to be the attachment proximally. Next, what is going to be the attachment on the distal aspect? You know, the distal attachment is going to be on the tibial plateau. Now in the tibial plateau, we are having a bony projection in the form of a tibial spine. So one of the ligament is attached anterior, other is attached posterior. So ACL will be attached anterior to the tibial spine. So it is attached anterior to the tibial spine on tibial plateau. All right. So this is how the anterior cruciate ligament is attached. Next point is, so this is about the anterior cruciate ligament injury. Point number 1, the attachment. Next, as all of you are aware of the fact that it is intra-articular, it is extrasynovial, it is a ligament which is preventing the anterior translation of the tibia on the femur. You know, the main function of the anterior cruciate ligament, the major function of the anterior cruciate ligament is to prevent the anterior translation of tibia. All right. Now, imagine if there is no ACL, then what will happen? This stability will be compromised. So every time you put weight on the tibia, then there will be anterior thrusting of the tibia. This anterior thrust of the tibia is prevented by anterior cruciate ligament. Now, if the anterior cruciate ligament is injured, if because of the rotational injury, the anterior cruciate ligament fibers are ruptured, it is injured, then what it will lead to? That means, what are the tests which are required for the confirmation of anterior cruciate ligament injury clinically? What are the clinical tests which are required for the confirmation? So what are the tests for the ACL injuries? Now one of the tests is a Lachman test. You know what happens in Lachman test? That you flex the knee joint to 20 to 30 degree. You are not going to flex the knee joint to 90 degree. Just 20 to 30 degree of knee flexion. So 20 to 30 degree of knee flexion. And then you try to translate the tibia. You try to move the tibia. You try to move the leg anteriorly. Now it goes if there is a appreciable translation in comparison to the normal one. That means anterior cruciate. So it is a provisional diagnostic test. That means anterior cruciate ligament could be injured. So that is a Lachman test. Now, one of the important fact about the Lachman test is that it is the kind of the test which you can perform immediately after injury. All right. So you can perform it immediately after injury. This is the kind of the test which you can do immediately after injury. All right. You will not wait, or this test is not going to be too much painful for the patient that he will not allow you to perform this test. You see what happens is, imagine if the patient is having a ACL rupture, then there will be a hemarthrosis. There will be massive collection of the blood inside the joint.